the 2 sessions, in fact 3 sessions and 2 topics that we have covered previously, this one is pretty easy. Olfactory groove meningiomas are relatively straightforward to understand. The surgical approach is also relatively straightforward in comparison to what we have covered before. So I am sure that all of you are going to breeze through this today, inshallah. So without further ado, we proceed. Before we move to the pathology itself, I think you all are familiar with my pattern now. We cover the anatomy, the relevant surgical anatomy first, and then we move to the pathology so that the surgical approach makes sense to all of us and we are on the same page. So, anatomy of the anterior cranial fossa is very straightforward in comparison to middle cranial fossa or the posterior. What do you see here? We see the ethmoid bone in here. We see the frontal bone. This here is the sphenoid bone. And in the midline, there is a bony protuberance, which is called crista galli. And why is it important? Because it gives the attachment to the fossa cerebri. And this little bone here is the cribriform plate. And why is it called cribriform plate? Because there are a lot of small punctures or holes for the rootlets of olfactory nerve, and olfactory bulbs lie just above this plate here. And this suture, which is the ethmoid bone and the sphenoid bone together, this suture is the actual origin of the olfactory groove meningioma. So, moving on. This is a cadaveric image and is still relatively easy to understand. So, and the structures are marked, but let's still take a guess. What do you think is this? So what are these?
Olfactory bulb.
Yes, exactly. These are olfactory bulbs, and these are situated right on the base of the anterior cranial fossa, just above the dura. Above it, we have the orbital gyri, we have the gyrus recti, and they are covered by it. If we take it apart, we will see small nerve roots like this. I'll draw here. For example, if this is the olfactory groove, then it has these small nerve roots which are entering the skull base via the cribriform plate. So the function of the cribriform plate is to allow these nerve roots to enter in, and we have this olfactory bulb which runs slightly posteriorly. Below it, what do we see? We see chiasm, right? And if we follow the chiasm anteriorly, we can see that, let me change the color, we can see that it's going to continue as optic nerves bilaterally, and obviously the nerves are within the optic canal and covered by the dural sheath, so you cannot see them because this entire thing is still covered by the dura. Then we see the chiasma here, which is slightly posterior, and let me change the color again. What is this? Without looking at the labels, what artery is this?
MCA.
Sorry?
Cerebral artery. MCA.
No, this is not MC. Just give me a minute. I think I drew it too far. What do you think this portion is? This portion only.
Bifurcation of the carotid.
Exactly. So we have ICA here. This is still ICA. Bifurcation of ICA. Then here we have the MCA. And then here on this side we have ACA. And what segment of ACA is this?
A1.
Yes. So this is pre-communicating. This is A1. Change the color just. So this is A1 here. What do we see going above like this? These two paired structures. What are these two?
A2.
That's right. These are A2. No. These are A2. So what ends up happening is we have these ACA here, which go like this from here as well. And then there is this communicating artery, which is the ACOM. And then this is the A2 segment. Now, there is another artery, which is really important from the surgical perspective because we do not want to hurt it. There is this artery which either arises from the A2 or the junction of A2 and ACOM, which slightly courses back. What is that artery called? It's not visible in this image.
recurrent artery segment.
Yes, that's recurrent artery of Hubner. And why is it important? Because when we end up dissecting the lesion till here and we reach this region, let me clear all this up. When we reach around here, if we are not careful with how we are dealing our vessels, we might inadvertently injure the recurrent artery of Hubner because it has varied origin. Sometimes it can arise from A1, sometimes it can arise from the junction of A1, A, and A2, and sometimes it might arise from here. So when we are dissecting, we need to stay in the arachnoidal plane and we need to watch out where the recurrent artery of Hubner might be. Also, please orient yourself. We are looking at it from top down. So what are we going to see? We are going to see the vessels on top of the chiasma, right? But when we are operating, the patient is extended. If you imagine, then this portion is not going to be the floor. It's going to make your surgical roof. Am I making sense?
Yes.
Yes.
Right now, we
Yeah.
are looking at it top down. Okay, so this is the normal anatomic view. But when we are operating, this entire thing is the roof of our surgical field. I am not saying the roof of anything else, it's the roof of our surgical field. So, what is going to happen is the vessels are going to be below, the optic nerve is going to be above it. This is an orientation problem that sometimes residents they sort of forget to reorient themselves, that there is some difference between the anatomic views and the surgical views. The surgical view is going to be reversed. Okay, what else do we see here? We see the infundibular recess here, and here, there would be pituitary. This is the mammillary body. Somewhere around here, there will be lamina terminalis as well. When we look at it after we dissect these vessels here, and you can see the posterior cerebral artery going back here. PCOM is also visible somewhere around. So this is a small area, but with a lot of intricate structures. Good thing is we stay here. We do not go beyond this portion usually until and unless the olfactory groove meningioma is also involving sella. So moving on, are we all on the same page?
Yes.
So this is another cadaveric image, and just to orient yourself better, it is still the anatomic view. What are we seeing here? We have the cribriform plate here. We have these olfactory bulbs, and since it's cadaveric, these are shrunken. We can see the orbital roof here. And when we come back, we can see that this is ACA, which is arising from this here is ICA. It's bifurcating, going this way is ACA, and on the opposite side, we have the MCA. These go above and make the A2. And here you can see the recurrent artery fibula, which is arising from the A2 very clearly. So moving on. Again, now we have taken down the vessels. You can see that the ACA is not getting continuation anywhere. Here, it would have been like this, but it's not. And we have taken it away. What we see is a very beautiful view of optic nerves, the chiasm, and we also see the lamina terminalis here. If when we are operating on these patients, if we go slightly posterior, then we can appreciate lamina terminalis. And what is this? This is the pituitary stalk. And if you see these edges, these are the edges of anybody?
Sphenoid.
No, no, no.
Sphenoid.
Look at it again.
Big
Diaphragm
charismatic.
masala. Who was
Big
that?
charismatic. Yeah.
Yes, that's right. When we are saying that this is pituitary stalk here, and the pituitary gland is obviously going to be lying down, then this is diaphragm masala. You can see that it is dural attachment. So, moving on to the next slide. Okay, this is another beautiful cadaveric image. And where's the surgeon? Where's the surgeon standing? Where are we located right now? Because it's really important that you establish the anterior and posterior in these kind of images. So this is anterior.
Anterior
Okay.
view.
Yeah, this is the anterior, this is the posterior view, in a way that this is in front of us, right? So we see in the ACA, which is going beautifully here. We see the ACOM, which is very small. We see the A2, and we see the recurrent artery of Hubner. Below it, we see optic chiasm and optic nerves. And you can see the infundibulum. You can also see, what is this structure that I just marked? What is this? That's right. So when this is infundibulum, then this is going to be pituitary gland. And if you see, this region is the diaphragma sala edges. So moving on. This is how the surgical view is going to look like. Now, if you see, you'll realize what I meant when I said that the base here, this base here, makes the roof of our surgical field. Now, whatever the base was, is our roof. You see the olfactory nerves here. And since they, am I audible?
Yes.
Yes.
Okay, so you see the olfactory nerves here, and somewhere around we have the roof of the orbit, and this here is dura. We have, assumingly, we have taken down the tumor, and these are the frontal lobes, which we are retracting. Sort of, let me clear this, we are retracting them here. Now, what are you going to see? You are going to see the chiasma first, and behind them is the vessels, the structures that we discussed before. So this is the surgical view, and all the previous images that I shared were the anatomic views. Okay, so can somebody explain what is going on in this image? Anybody? Okay, I'll continue. So this is the ophthalmic artery, right? This, let me clear. And we have this ophthalmic artery, which is going in the orbit, and then it reaches the medial wall of the orbit, and it gives two branches, which are posterior ethmoidal artery and the anterior ethmoidal artery. Okay, and then these branches pierce the medial wall of the orbit, and then they come up again in the anterior skull base via the cribriform plate. So these are two major blood supply of the olfactory groove meningiomas. These are the major feeders, and hence these are the reasons we do not go for angioembolization preoperatively in olfactory groove meningiomas, because they are a branch of ophthalmic, and if we end up taking this, then we might risk blindness in the patient. Also, can somebody tell me what is the medial wall of the orbit called? And why is it called so?
Preparatia.
That's right, that it's called lamina papyracea. Why is it called so? I think it's pretty odd, visible in the name. Why do we call it lamina papyracea?
Thin.
Yes, it's very thin. It's very thin, it's paper-like, and since the blood vessels are also piercing it or perforating it, the bone is a potential site of weakness. Why is it important for us? Even though we are not going to discuss the endonasal endoscopic approach for olfactory groove meningiomas, lamina papyracea is the medial limit of the endonasal resection. When we are resecting the bone, when we are taking out the olfactory groove meningioma via the endonasal approaches, lamina papyracea is going to be the medial limit. I had an image to convey this better, but I have forgotten to include it in the presentation. I will probably send it on the group. So moving on to olfactory groove meningiomas, we are all on the same page regarding the anatomy, right?
Yes.
Okay, so they're really, really easy. There isn't much to learn, especially if you're slightly senior. If you're first year resident or second year resident, you might have something new to learn here. Otherwise, olfactory groove meningiomas are pretty basic. The important thing is to distinguish them from the tuberculum sella meningioma. How do we do that? The first thing is obviously the dural tail. Apart from the dural tail, we want to see what part of the bone is hyperostosed. If it is olfactory groove meningioma, then the cribriform plate and the region around it is going to be hyperostosed. If it is tuberculum sella meningioma, then the region around tuberculum and what is that called? The chiasmatic sulcus, that portion is going to be hyperostosed. So hyperostosis is one sign. Dural tail is another sign. What are some other signs? We have the position of the chiasma. Olfactory groove meningiomas depress the chiasm. They grow like this. It goes like this. I'll draw it. So this is sella here, and this is clivus. Here are the olfactory groove meningiomas, and somewhere here is the clivus. So when they end up growing, they end up depressing the clivus, and the clivus goes below it. Okay, so when the clivus is below it, what is that going to mean for us in terms of patient presentation? Clivus is below the olfactory groove meningioma. I'm going to draw it here, assuming that this is olfactory groove meningioma. And so I'm sorry, I have been saying clivus. I wanted to say chiasm. You're not confused, are you? I meant to say chiasm.
Yes, yes.
Yes,
Okay,
now
so
it's clear. Huh.
we have done a lot of clival anatomy, and it has it has stuck on my tongue. That's okay. I hope you all understood. So this is chiasm, and these are the olfactory groove meningiomas. So when they get compressed, the superior portion is going to get compressed. So when the superior portion is going to get compressed, what are we going to have? We are going to have inferior field
Yes,
defect. That's right, which is very typical for olfactory groove meningioma. For tuberculum sella meningioma, we usually have bitemporal field defects. Okay, coming back here, olfactory groove meningiomas, they displace and depress the chiasm inferiorly, whereas tuberculum sella meningiomas displace and elevate the chiasm superiorly. Let me move on to the next slide. Okay, so we have already discussed the hyperostosis of underlying bone. They can involve the ethmoidal sinus. They can also involve sella in some cases. And olfactory nerves are usually displaced laterally. If the meningiomas are really giant, then they can encase the olfactory nerves. Otherwise, they're just displaced laterally. A really interesting thing is, even if you end up saving the olfactory nerves surgically, patient might still have anosmia. Why is that? Because long-standing compression can cause a permanent atrophy in these nerves, and patient might have permanent anosmia even if you managed to save the olfactory bulb during the surgery. ACAs are displaced laterally and posterior superiorly. Now, this is really important, and it's important to note the position of ACAs and other important vessels on the T2 weighted images. We can see the phlovoids, and we can see whether either of them is encased or displaced, and we would have a clear idea of what to hope during the surgery. So the major blood supply is from anterior and posterior ethmoidal arteries. We have already discussed it. There are other arteries that can supply, for example, middle meningeal artery can give sphenoidal branches, and there can be pial breach, and it can lead to the excessive vascular supply to the olfactory groove meningioma and a lot of edema. If there is a lot of edema on the preoperative image, if we see a T2 weighted image and there's a huge edema around the lesion, it usually means two things. It means that either the lesion is driving its blood supply from pia, there has been pial invasion. We discussed this concept yesterday as well. Anywhere in the brain, if the lesion was initially extra-axial, but now it's driving its blood supply from the pia, or there is invasion of the pia, then there's going to be a lot of edema. Apart from that, what is important in terms of olfactory groove meningiomas is venous engorgement. So the sinuses are compressed, or the bridging veins or the draining veins of the frontal lobe, they are compressed. Hence, there is a lot of edema, and there is stasis of the interstitial fluid. So when we see edema out of proportion to the size of the lesion, it usually means there is bile invasion or there is venous involvement. Am I clear?
Yes.
Okay, I'll move on. Clinical presentation is very easy. We all know anosmia, the earliest but the most ignored. Then we have the frontal lobe syndrome. Patient can have apathy. Patient will be very indifferent. There will be a loss of initiation. These patients are really, really difficult to examine and really difficult to take a history from because they will not cooperate with you. They will not tell you anything that you are asking from them, and they will just, diminish you or tell you to not bother them. So there is this severe indifference towards their own condition and their own symptoms. Then there is disinhibition. Disinhibition means that the patient loses the ability to behave in an appropriate manner socially. So the patient is going to behave in a very, very inappropriate manner. He might abuse publicly, he might urinate publicly, he might take off his clothes publicly. So there, this disinhibition feature is something which is characteristic of frontal lobe tumors, but it is also something which can divert the patient towards psychologists and psychiatrists. There will be personality changes, irritability, and socially inappropriate behavior. Memory impairment, obviously, if the lesion is big, it's going to impair the patient's memory as well. Then we have the progressive visual loss. It can be due to direct compression of the optic nerves or chiasm. It can be due to raised ICP, inferior field effect we have already discussed because the superior portion of chiasm is getting compressed. Then we have Foster Kennedy syndrome, written a lot about in the books, but I have not seen a patient with Foster Kennedy syndrome during my residency. And it's relatively rare, probably because of the advent of the imaging. Maybe we don't see it as much. We have the ipsilateral optic atrophy and contralateral papilledema. You all with me so far?
Yes.
So pretty basic signs of raised ICP. There will be gait ataxia. Ataxia, or you can also call it apraxia, because the patient's supplementary motor area would be involved. Hence, the initiation would be difficult. There will be magnetic gait. Urinary incontinence can be there, especially if and there is pressure on the medial portion of the frontal lobe. Seizures are very less likely, but if it is a giant olfactory groove meningioma, then there might be cortical irritation leading to seizures. This was very easy. We breezed through it. Now we come to the investigations. They were also easy. We know that we need an MRI brain with contrast. Apart from that, we are also going to need a CT, specifically CT coronal sections bone window, because we want to see if there is any hyperostosis of the bone we are going to be working with. Because if we end up leaving any hyperostosed bone, it can be a nidus for the recurrence of tumor. What are the functional tests? Obviously, we are going to need perimetry and fundoscopy. When do we do endocrinology? So I have some images ahead. I will ask you, when are we going to order endocrinology? So MRI features are pretty typical of what usually are in the meningiomas. We are going to have homogeneous contrast enhancement. There's going to be dural tail, often significant edema. What is important to see on MRI is the ACA complex. We want to see where the ACA is placed, whether it is displaced, where it is at present, if it is encased in the lesion. We also want to see the A2 segment and the pericallosal segment, whether they are displaced too far behind. We have already covered this. Extensive edema is often due to blood supply from pia and compression of frontal draining veins. Moving on. So, can somebody volunteer and go over these images, please?
Dr. Kamal, can I try?
Yeah, sure.
Okay. The first image is axial section, MRI axial section, a T2 weighted image is showing a iso-intense lesion in the interior cranial fossa, well circumscribed with the surrounding edema. If that is vasogenic, and then next image is showing that is axial section of MRI with the flare images, and they also showing there is a extensive edema. And the third image is it is showing it is a homogeneous contrast enhancing lesion in the center of the interior cranial fossa with the some blood vessels at the periphery of the lesion. Thank you.
Okay, so that is more or less accurate. A very good idea is to not comment on the blood vessels on the post-contrast sections. Blood vessels are usually more apparent on the T2 sections. We can, if we see that there is engagement or if something is very, very significant, which was not the case here. So it's a good idea to let it pass. So what do we see here? Can someone else volunteer now? Anybody?
Dr. Kaval, if
No?
no one is, then can I try, please?
Yeah, I think nobody is. Everybody went suddenly very quiet. You can.
Okay. The first axial image, MRI image, is contrast with T1 with contrast, and it is some globular type of lesion in the interior cranial fossa, and the other is a sagittal section of the T1 with contrast, and it is showing the lesion is arising from the interior cranial fossa, most probably from the cribriform plate, and it has extension into the tuberculum sella as well as into the dorsum celli, and it is causing the compression of the frontal lobe superiorly. The other is the coronal section and showing the marked extension into the frontal lobe. Thank you.
Okay. So yes, this is a well circumscribed, homogeneously enhancing lesion, and the section is axial T1 post contrast. What is interesting is that there is involvement of ethmoidal sinus somewhere here, and there is also involvement of sella. So the dorsum sella is here. This region is the dorsum sella where my pink cursor is, and then posteriorly it continues to the clivus. When we see that the lesion is in here, we do not usually individually comment on the tuberculum sella, etc. We just say that it is invading the sella as well, or it is involving the sella as well, right? Moving on.
Okay.
So, what kind of investigations are you going to get done, and what other things can you notice on this image?
Um, uh,
What is going on here? Yeah. So, what's this? Okay. So, what is going on here?
compression of the interior cerebral artery posteriorly, displacing it posteriorly.
Yes. So the A2 segment most likely, and the probably A3 segment is also displaced posteriorly. We also see the displacement, significant displacement, in fact, of the corpus callosum. Apart from corpus callosum, which important structure is getting displaced here significantly?
Stock. There is stock.
Yeah, and look above the pituitary stalk. What do we see here?
corpus callosum, great gyrus.
Yes, corpus
Chiasm.
callosum. And
Chiasm.
yeah, and chiasm would be obviously would be compressed. Hypothalamus. Can you see the third ventricle is not in its normal position? It's displaced, right? It's displaced, and along with it, hypothalamus in this region is also displaced. It's getting compressed. So this patient might have the features of hypothalamic dysfunction post-operatively, diabetes insipidus, a lot of hunger, etc., etc. Please give me a minute. I'm really sorry for the interruption. Okay, coming back. So we have significant compression of the hypothalamus, and what we were discussing was that postoperatively, these patients can present with the hypothalamic dysfunction, which is going to be really, really difficult in terms of how we manage. Okay, there was another important thing that I wanted to discuss in the previous slide. Let me go back. So, as a surgeon, what would be my concern for this patient postoperatively, even if I have done a gross total resection?
Post-op edema.
Yeah, so what is that going to mean? The patient's recovery is going to be slower, right? Because there's going to be a lot of edema. He might still have altered level of consciousness. Just give me a minute. He might still have altered level of consciousness, and these patients might be drowsy. They can be difficult to wake up postoperatively. And sometimes what ends up happening is, even if the patient was initially okay, a few hours later, the patient can suddenly deteriorate due to excessive edema. So it's really, really important to keep that in mind and to keep a really good eye on the patient when you are operating on a patient with olfactory groove meningioma that has a lot of edema. So I will change the slide. Moving on. Okay, so can somebody comment? It's really easy. I think I would just go over it very quickly. You can see that there is some bony hyperostosis, which is going to be really difficult. And there is involvement of the ethmoidal sinus right here. So when there is involvement of ethmoidal sinus, usually these patients are a relatively good candidate of endonasal endoscopic approaches, because this is going to be our natural route either way. But in this patient, we are going to avoid it because the height of the tumor is significant and it's going to be really difficult to get the entire chunk of the tumor out. Moving on. You can again see, okay, Dr. Sana, see this is a section which is a post contrast, and
Yes.
it's T1 weighted image, but we are going to comment on the vessels here because they are getting, you see,
Encasement.
yes, there's encasement of ACA. And when there's encasement of ACA, as a surgeon, we are, I'm not sure anybody would be looking forward to it because it would be really difficult to peel it away. There is not only encasement, there is also stenosis of the lumen as well. So this is again another image. And what investigations are you going to get done in this patient? Apart from MRV that somebody said, why do you want an MRV, by the way? Who was this that wrote in the chat box? I don't know the name, but usually MRV and angiography do not have a significant role. One can get it done if they are suspecting that there is significant involvement of ACA complex. In these routine investigations, it does not have a significant role. What other important investigation will you get in this patient, which you would not in a normal olfactory groove meningioma patient?
Endocrine workup.
The crying.
Exactly, because there is significant cellular involvement. So we are going to order the pituitary profile. We want to see if patient has any hormonal disruption. So moving on, you can see that these two images show the hyperostosis of the involved bone. And okay, so we have already discussed, I would just go briefly over it. There is no significant role of preoperative angioembolization. Why? We have discussed. I meant to ask this from you people, but I forgot and told it in the beginning. Anterior and posterior ethmoidal arteries arise from ophthalmic artery. Hence, we do not usually go for preoperative angioembolization. So, the management and the surgical approaches, observation and SRS, both are an option if the tumor is under 2.5 centimeters, because these are very slow growing. So we can offer patient both. We can get them a cytotactic radiosurgery. We can also keep them on follow-up with serial MRI. There are a myriad of surgical approaches that can be used for olfactory groove meningioma surgery. You can use the subfrontal or the extended transbasal approach. You can go via terional, you can go via supraorbital, interhemispheric, endoscopic, endonasal, etc. It varies from case to case. So when are you going to go subfrontal, transbasal? Can somebody volunteer and let me know? What kind of patients favor this approach?
Bilateral involvement.
Involvement of the
Okay,
Moderate.
bilateral involvement and
Medial.
sorry. And there's a very common indication, size, no? If it is really, really big, it's going to be really difficult to take out via terional approach because terional approach only gives a unilateral idea, right? So bilateral and huge meningiomas, also surgeon's preference. I personally like subfrontal approach because it provides a lot of exposure. Yes, there's more post-operative morbidity, but the exposure is really beautiful. That exposure is slightly difficult to achieve via terional approach. So when are you going to go via terional approach?
Like lesion extension is towards one side more.
Yeah, so the lesion extension is more unilateral and it has a very important benefit that the other approaches don't usually. It can preserve what?
Recurrent arterial.
No. Recurrent artery fumeur is something to be preserved via any approach that we use. We cannot risk sacrificing it. Terional approach is usually really, really good to preserve olfaction because you can preserve the opposite, the contralateral olfactory bulb. So if a patient has a preoperatively preserved sense of smell, then terional approach can be given a consideration because other approaches are going to lead to postoperative anosmia. So unilateral and we are going to have to preserve the olfaction. These are two important considerations. Then supraorbital keyhole, obviously it's minimal invasive and it's going to be associated with significantly less morbidity. Interhemispheric is very rarely used in, I think, very typical cases. I have never seen it used during my residency. I have never used it either. Then we have the endoscopic endonasal approach. Endoscopic endonasal approach has some benefits, but it also has some cons. You cannot preserve olfaction. Also, if the ACA ACOM complex is slightly anterior, then it's going to be a problem because when you go via the endonasal approach, you're going to approach the vasculature first. There, I have a comparison table ahead. So it's okay if you don't retain all of it. I'm going to upload the PPT so that you can always go back and take a look at these tables. Bifrontal approach, by which I mean the extended transbasal approach, usually with giant tumors, but olfactory nerves are almost always sacrificed. And the view is good, but we get late control of ethmoidal feeders. We can, by the way, address it. What do we mean by late control of ethmoidal feeders? Can somebody explain that? No? This is a very easy topic. I expected more of you to talk.
Because you, can I trust?
Yeah, sure.
Because you approach from the contralateral side, so it last one to go deep inside.
Kind of. So bifrontal approach has slightly a later control of ethmoidal feeders. Why? Because to approach these ethmoidal feeders, we need to do what? Orbital osteotomy. And once we take the orbital bar away, then we can slightly retract the periorbita and approach the anterior and posterior ethmoidal arteries. I have a figure ahead. I'll show it to you later on. These have significant frontal lobe retraction. if your position is not right. So what is the ideal position for bifrontal? We slightly extend the patient and glabella is the highest point. Why are we extending? Because we want to do because we want gravity to do the job that retractors would have done. So we are aiming for gravity-based retraction. But even then, that's probably one of the biggest criticisms this approach has. Terrenal approach is used for small to medium tumors that have more extension on one side. Olfactory bulb can be potentially preserved on the contralateral side. We have early control of ipsilateral ethmoidal feeders, and there is minimal retraction, but the corridor is really, really narrow. For endoscopic approach, we want midline tumors that are slightly flatter. What do I mean by flatter? We don't want a tumor that looks like this, which has a lot of height in terms of the tumor mass. We want tumors that are more or less basal so that they're easier to debulk and take out via the endoscopic approach. Clear all of this. Again, endoscopic approach also gives early control of ethmoidal feeders, and obviously there is no brain retraction involved. It's a minimally invasive approach. Then we move on to the next slide. Bifrontal approach gives a very good view of optic apparatus. Terional only shows the unilateral approach, unilateral view. It's really difficult to get a good view of the contralateral ICA, the contralateral optic nerve, etc. And endoscopic approach obviously shows a direct view. Then sinus management. We can easily avoid superior sagittal sinus when we are doing terional approach. But when we are doing frontal approach, bifrontal approach, then we usually ligate it right at the base and then we retract it upwards. Hence, it has this minimal risk of postoperative venous engorgement and edema and infarct. Then we have, let me clear. Okay, so there is not much of a difference in terms of risk factors. Bifrontal approach has venous infarction. Terional approach has limited view of the contralateral side and vessels. And endoscopic approach has high risk of the CSF leak because obviously we are opening up the skull base. This was a table that was in Mefty. I thought to include it, but it has more or less whatever we have covered previously. So, you operated a patient with cross-total resection and the surgery went beautifully. But the patient deteriorated after 8 hours with sudden altered level of consciousness or seizures. What might be the cause or causes?
Post-op edema.
And
bleeding,
and
Hematoma.
Bleeding.
okay, before bleeding, what can happen? Because obviously, if any good surgeon is going to secure hemostasis before they are closing the patient.
Infarction.
Infarction, exactly. Patient might have a venous infarct. A patient with very huge olfactory groove meningioma can have venous infarct postoperatively, especially if the handling of the deep venous system or the bridging veins was not meticulous, and if the patient had a lot of edema preoperatively. So we have discussed this very thoroughly. I am moving on. Subfrontal approach. How are we going to position the patient? It's all written here, but I would still go briefly. Before the position of the patient, we can put an LP drain or we can do a frontal ventriculostomy. I have seen my seniors instead of putting an LP drain, they usually ask the anesthetist to do the LP and drain a small amount of CSF so that the brain is relaxed. But there are surgeons who would rather put an LP drain in there, and there are surgeons who might have a frontal ventriculostomy. So it depends on what you want to have as the surgeon. Then the patient is positioned supine. The patient is going to be positioned supine, and the head is going to be slightly extended. Why? Because we want gravity to do our work. We don't want to have fixed retractors, because using fixed retractors in such surgeries is going to increase the risk of seizures to quite a significant value. Glabella must be the highest point in the surgical field. And moving on. So everybody has preferences. I usually prefer this incision. You might have other preferences when you do the bifrontal craniotomy. We are all familiar with the incision. We start from 1 centimeter in front of one tragus, and we move to the opposite tragus and staying 1 centimeter ahead of it. I like to make this widow's peak. There are surgeons who use these zigzag lines because they find it easier to approximate. Let me move. So after the bicornal incision, which is also called the suture incision, we raise our skin flap. So there is some difference between what the image is and what my usual clinical practice is, or what I have seen my seniors do as well. The image depicts a flap which has both the periosteum and the skin, etc. The scalp and the periosteum are raised in a single flap in this image. What we usually do is we raise a separate scalp flap, and then we retain the periosteum. Then we give an incision here with the help of monopolar cautery, and we perform subperiosteal dissection for the temporalis muscle, and then we retract it inferiorly, bilaterally, so that because the keyholes are going to be slightly here, okay? And to reach the keyhole, you need to retract the temporalis muscle on the other side. So if somebody wants to comment what is their institutional practice or what do they do in their own clinical practice, I'm more than happy to know. Anybody want to add their own contribution to this? Are you all sleeping?
No, we do the same.
Okay. I
Well,
think the
at
only
our institution, we do a myocutaneous flap.
okay.
We don't detach
Okay.
the temporalis. We raise it together with the skin to protect the fascia nerve.
Okay, so you raise the temporalis muscle along with the scalp flap as a myocutaneous flap.
Right, that's it.
Okay. Okay. So what we used to do is we take an incision here, a separate incision here, and we do a subperiosteal dissection. And I also undermine the posterior margin of a bicornal incision because I want a slightly larger periosteal flap. Because when we harvest the periosteal flap now, and if you have also undermined this, then you can just retract the skin and take some more periosteum. It gets difficult when we reach the corneal suture because the periosteum is densely adherent to the suture. But till the suture, you can still, get a really generous flap out. The bigger, the better. So moving on to the next step, you can now see the keyhole which is exposed, and I am glad this person is using my dissection. So this is a periosteal dissection of the temporalis muscle. And you can see they have exposed the keyholes very beautifully. You can also see that the orbital rim is slightly exposed. What we do is when we are exposing this region, we want to look out for what nerve or what neurovascular bundle do we look out for?
Yes,
Frontalis
Supraorbital nerve. When we are talking about this region, there's a supraorbital nerve here. I have pictures ahead. I will show you. We want to retain it and we want to mobilize it along with our scalp flap. Let me clear this and we can move on to the next slide. So you can see that you have the supraorbital neurovascular bundle here, which has been mobilized. Why do we mobilize it? Because we are going to take the superior orbital rim when we are going to do the orbital osteotomy. So it's really important to preserve it. Okay, so this is a beautiful illustration. You can see that here is the superior orbital nerve. It has been mobilized along with the flap. You can see the cue holes bilaterally here. This here marks the position of superior sagittal sinus. Let me move. So everybody has a different way of doing craniotomy. We usually raise it in a single flap. There are people who take it in dual flaps. They do unilateral frontal craniotomy, then they do another craniotomy on the opposite side, then they take the bar in between. That's usually not my clinical practice, but that's okay. These are surgical preferences and everybody is entitled to have their own. So now you can see that the entire craniotomy has been done from one keyhole to the other keyhole. This is one keyhole, this is the other keyhole, this is the superior sagittal sinus, and these are the frontal sinuses here. I'll change the color. So for the residents who are new to the neurosurgery, please remember that whenever we end up opening a sinus, we take out the posterior wall and we also take out whatever mucosal content is within the sinus. We call this procedure cranialization of the sinuses. So we are going to make sure there is no remaining mucosa within the frontal sinus because it can lead to formation of mucocele postoperatively. And if we slightly retract here in the midline, we are going to find crista galli and the attachment of the fossa cerebri, which we are eventually going to dissect. So here you can see the margins of orbital osteotomy. For that, we use a saw. These are the margins of the orbital osteotomy. There are surgeons who use this small orbital osteotomy, but it usually does not make sense to me. This one gives you a very good view of the entire skull base, because along with this, we are also going to take some part of the orbital roof. And you can see that the superior orbital nerve is preserved here. Let me move. Okay, now you can see here in this image, you can see that the crista galli has been taken away, and obviously it was detached from the fossa cerebri attachment. You can also see that part of the orbital roof was taken away here. And these are the periorbita, the fat that surrounds the content of the orbit. So now we have a really, really good view. If we even slightly retract this frontal lobe here, we are going to find the tumor looking right at up. And oftentimes the tumor is so huge that it is retracting the frontal lobe itself. And as soon as we do this, it's visible. So this is an illustration from Mefty, and you can see what is going on here. After they have done the orbital osteotomy, they are retracting periorbita slightly, very, very gently, and you can find anterior ethmoidal artery here. And you can also find posterior ethmoidal artery here. They are both coagulated right here before they even feed the tumor. This single maneuver alone can decrease the bleeding during the surgery to a significant amount. So this is how we open the dura. You can raise two flaps and you can tie the sinus here. You can simply tie a suture here and then incise it, retract it upwards. It's straightforward, right? Or do you want me to go slow?
It's clear.
Okay, so when we are done with resecting the tumor, this is the view that is going to be. We can see the ACOM, we can see the A1, and we can see A2, which is going to come towards us. And you can see the frontal lobes here. Okay, so this was it for the bifrontal transvasal craniotomy. That was it. We have certain complications. Somebody wrote in the chat box before that we can have frontal lobe syndrome postoperatively. There can be permanent changes in personality. There can be decreased executive function. There can be a risk of venous infarction. There can be brain edema or contusion if we have used fixed retractors, or if the person who was handling the retractor was not too careful with them. CSF rhinorrhea is obviously a problem because we are taking away all the dura of the skull base. What we end up doing is we repair it with the periosseal flap we secured in the beginning. We take that flap and we sort of lie it down in the entire skull base anteriorly, and then we take a suture as deep as we can go, and then we use the fibrin glue around it to secure the skull base. Otherwise, the patient is going to have CSF rhinorrhea. Frontal mucocele is only a problem if you have left some sinus mucosa in there. If you were really vigilant with taking out all the mucosa, then it's not going to be a problem. Meningitis, obviously we are opening the dura, and there is this risk of nasal cavity and the sinuses as well, so the cavity can be contaminated. Visual deterioration can be a post-op complication. DI, when does DI happen? We already discussed that. If there was involvement or compression of hypothalamus, if the hypothalamus was significantly displaced, then patient might have diabetes insipidus. Patient can have obesity as well. Permanent anosmia is a complication. Cosmetic defects, if you are not very careful with where you are placing your burr holes, then it can become a big problem. Hence, a lot of people avoid any burr hole around the glabella. Then, obviously, suture incision is a really big incision. It can lead to wound descent. It can also lead to necrosis of the skin. So that's a wrap of a very long session. And any feedback, any questions, they're all welcome. I'm not sure why you have not been asking questions or interacting more, even though the number of participants have gone up. So please let me know if there are any questions, any feedback.
Thank you, Dr.
We will.
Kawal. Can I ask one question, please?
Okay.
Yeah, Dr. Kawal, can you please a little bit emphasize regarding the key burr hole, like after temporalis retraction, like location? It is frontozygomatic.
Dr. Yusra? Are you with us?
Yes, yes, I'm with you.
Oh, I think you.
Unmute. Yes, Dr.
Okay.
Kawal, I'm listening.
Okay, let me go back. So yes, it's the frontozygomatic suture. And let me go back to the picture. Once you retract the temporalis muscle, you are going to come across this depression, which is very, very visible. There is this frontozygomatic suture here, and right behind it, this is where the sphenoid wing starts as well. And you have to expose this portion, and you also have to, drill the portion on both the sides. So I'm not exactly sure what you wanted to ask. You went mute in between.
Yes. Actually, I wanted the same question. It is behind the frontozygomatic suture, right?
Yes, so this is
A
here,
point
and
yeah.
this is frontal bone. This is the zygomatic bone here. It's not visible. This is the frontozygomatic suture. Right behind it,
Yeah.
this depression. As soon as this depression starts, we use this to make a burr. And this is called McCarty's burr as well, McCarty's burr hole, and it's really important in the keyhole surgeries because it can simultaneously expose the frontal lobe and the temporal lobe as well. So the surgeons who are really expert in the keyhole surgeries, they use this for the exposure of both the lobes.
Yeah, thank you.
Okay, everyone, this is a wrap for today. Thank you so much for attending. I would put up this link to this session's recording in a while. And this is the last session of our week. We are going to continue from Monday, Tuesday, we are probably going to have Dr. Itazaz, and he would be covering approaches of the spine for all those who are appearing in their exams. And from Wednesday, I would probably take over again. So thank you so much. Have a good day, good evening from wherever you are watching. Thank you.